Okay, hello everyone. Welcome to the second case. For this case,
转天告一声，
we
然
plan
后
to
那个
perform one-stop
啊，
PCI and TAVR
动脉传感器
procedure and
出水了，可以了
extracorporeal
啊
circulation. Firstly,
我不抽血，
please,
我是量的啥呀？量髋板压
Professor
啊，你这
to
出好，
introduce
可以。
the brief case,
静脉你灌水吧。
but the brief information of the case for us.
Hello everyone, and I'm Dr. Liu. So many thanks to Professor Gong, and please allow me to introduce our team. And our first operator is Director Sun, and our second operator is Dr. Xu, Dr. Zhu, and Dr. Liu, and our moderator is Professor Tu and Professor Gong. So, Dr. Sun, would you like to introduce about yourself?
Hello, welcome. I'm the first operator. Next, introduce the case by Dr. Liu.
Yeah, great, thank you. And now let's take a look about our case presentation, and please show my PowerPoint. Okay, great. Okay, so the patient is 65 years
CPP
old male,
price.
and
Pressure.
the patient complained of the chest tightness and
Sorry.
shortness of the breath for many
Wait.
years. And that's dyspnea for 1 month, and there is a rough systolic murmur in the aorta valve, and the breath sounds in both lungs are coarse and wet can be heard. And also the risk indicates that the patient have the hypertension for 10 years. And the next, okay, sure, okay. And let's see the ECG. It shows atrial fibrillation, the arrhythmia, and frequent ventricle parameter. And the Holter shows that the AF is a faster ventricular rate and interventricular differential conduction. And the next, okay, so let's see the echo TTE evaluation shows the Vmax is 4.4 meter per second, and the transvalvular pressure gradient PG max is 80, and the mean PG is 45. And the VV is 10 centimeter, and the left ventricle EF value is 30%. So we can see that it's a poor cardiac function. And we have connected the actual external circulation, the CPB. And the LVEFD is 59 millimeter, and the cardiac stenosis degree is severe. So the next, okay, let's see the lab date, and it shows some abnormal value, like the TNL value was slightly below standard, but not doubled. It indicates that there may be some damage to the myocardium. And the NT-proBNP is significantly higher than the normal, and reflecting the risk of the heart failure. And the next, okay, now we can see the angiography about the coronary condition, and it shows a max plaque in the proximal wall of the right coronary artery, RCA. It shows the severe stenosis of the vessel. And about the middle wall of the RCA, it's a mild vascular stenosis. And the distal wall of the RCA is moderate stenosis. And the next we can see, okay, yeah, sure. It's RCA, the moderate and the mild condition. Okay, great. And the next we can see the CT imaging. The CT analysis shows the aorta is a type 0 BAV with a calcium score of the 527. And it's a moderate to severe classification. And we can see the classification is focused on the between the leaflet. Okay, and the next it's about, oh sure, we can see the CT analysis video, right? It's from it's based on the aorta route from the subvalvular LVOT 5 millimeter to the annulus plan and to the supravalve plan to AAO. And it shows type 0 and LVOT open dilated. And for the LVOT 5 millimeter plan, it shows the perimeter is 33.4 millimeter. And the STG is 35.7 millimeter, and the SOV is the mean value is 29.3, and the max is 21.7. And we can also see the annular parameter is 27.9. It's a little large, right? Okay. And we can also see the AAO 40 millimeter. It's about almost 40 millimeter. Sure. And we can also see the angle between the annular plane and the horizon plane, and the degree is 55. It's it's almost transverse hard. Okay, so the next, okay, and then we can see the coronary condition. It's the coronary analysis, and it shows that under CT, the leaflet length was less than the height of the coronary outlet, and with the overall coronary risk was low. It's fortunately, right? Okay, and the next is about the multiple plan analysis about the CT imaging, and we can see the supravalvular multiple analysis and the classification mainly on the lateral side of anchored leaflet and focus on the edge of the leaflet. And the supravalvular restriction zone was from 4 to 10 millimeter supravalvular. And for the supravalvular 4 millimeter plan is the parameter is 26.7 millimeter, and about the millimeter plan is about 25.6. And we can see it's the restriction range about the supravalvular situation. And so, depends on the situation, we choose the Torres artery from PCI Medical, the balloon. And the balloon size is 22 millimeter. And actually, the PCI Medical is a domestic Chinese company and was selected for the balloon pre-dilation. The valve strategy, we choose the Torres Elite AV29 valve. It's also from the PCI company. And we can see the next. Okay, maybe something. I have a problem about the PowerPoint, so maybe wait 1 minute. Okay. Oh, okay. Now we can see that. Great. It's about the projection angle about the CT imaging, and we choose 2 angles, and one is about the projection angle, it's RAO 30 and RAU 28, and another angle is also the insurginal position, it's about the LAO 33 and CRA 35 for variation about the valve release. Okay, and okay, the next we will see the access analysis, and the access analysis shows the good condition about overall valvular size and shows the insertion to avoid damage during operation. Okay, let's go to the next slide. Okay, now we will do a conclusion and our treatment strategy, one-stop procedure about the TAVR and the PCI. And our TAVR strategy is about we use the 22 PCI medical balloon do the pre-dilation, and we use the Torres Elite AV29. And for the PCI, we do the LCX and RCA and treat it with DES or DEB. and assist with CPD. And now it's about my part, and thank you everyone. And now we can see the next is about our valve introduction. Sure. So the Taurus 29 valve we use today is from PCI Medical, and PCI Medical is a domestic company from Suzhou, China, and who specializes in precision manufacturing and biometry handling technology. Their water valve Taurus Elite is a second generation retrievable valve with four valve size, like the 23, 26, and 29, and 31. The delivery system is about the 19 French and 20 French. And the Taurus Elite balance the valve design and balance the support on the influence size, allows easy management of the high calcification and BAV valve diseases. And the outer skirt of the valve is effectively slide on the width of the valve with strong the ratio support and maintain a large orange air with an EOA that is the 20%. And the hairs and the same with the index design valve like the other companies. And it is more suitable for Chinese patients with high calcification BAV. And we can see the next. So yeah, this is the Taurus Elite. Some features like the comfortability, the pushability, and the stable retrievability, and easy to access, and the calcium adjustment, and convenient with the snare. And it has some features like they can support the strong ratio power, and it can easy to access to the vessel. So our case today is moderate to severe calcification type 0 BAV valve with mild dilation of the AAO. So our choice of the device was based on the product's throughput, feasibility, and risk stability, and ratio support. So based on this consideration, we choose the Taurus Elite, a second generation retrievable product from PCI, which provides enough ratio support with good supplement to help reduce vascular complication. And with annulus of 27.9 and supravalvular from 2 to 10 millimeter, the anchoring range of the 24.7 to 27.3 millimeter. The AV29 valve oversize is in the range of the 9.3 to 13.2%, and the AV26 valve in the range of the 0.9 to 5.2 based on the annulus and the supra-annulus analysis and restriction. So we choose the Taurus 29 valve, this size, but we will also do the further confirm that the valve strategy choose during the operation by balloon sizing. So if the 22 balloon is seen with a significant mass, then we will consider maybe downsize the AV26, the Taurus valve. So that's about our strategy. Okay, and thank you. This is about my part. And so Dr. Tu, could you?
Okay.
Okay, thank you.
Thank you, Professor Liu. And now we will review the PCI procedure briefly. Okay, firstly, we should review the baseline and coronary angiography, as shown in the before angiography. We can see there are significant lesions in circumflex and RCA, and with significant and severe stenosis. Firstly, okay, there are also significant stenosis in the RCA of the proximal and middle and distal segment. For RCA lesion, we implanted 3 DES and 1 DB at the significant stenosis, and we will review the final angiography result. Okay, this is the final angiography, and of course, our PCI procedure is performed under the guiding of the intravascular imaging with IVAS. Then we finished the PCI procedure for the circumflex lesion, and we implanted 2 DES from the distal to the proximal segment of circumflex. And the final angiography result is also very excellent. Next, we will perform a TAVR procedure, and I think we will successfully finish the complex procedure for this patient.
Okay, from Dr. Liu introduction, we know this is a 65-year-old male with a history of coronary artery disease and hypertension. He was admitted to our hospital due to chest tightness and shortness of breath for 1 month. Now he was diagnosed with severe symptomatic aortic valve stenosis, ischemic cardiomyopathy, and heart failure. His left ventricular ejection fraction was only 30%. His coronary angiogram demonstrated over 19% stenosis of the RCS branch and serious and long stenosis of the right coronary artery. Okay, Professor Gong, how do you choose the surgical strategy? You choose the one-stop PCI TAVR strategy or PCI before TAVR strategy for this patient.
Okay, as we know, a coronary artery disease and aortic stenosis, also coexistent, and this is about 75% in patients who undergo transcatheter aortic valve replace. Additionally, severe coronary artery disease is associated with increased mortality after TAVR. But how to manage coronary artery disease in patients undergoing TAVR still remains a clinical challenge. A time of PCI, I think, is a very important factor, but the type of PCI, as we know, the lesion preparation before stenting and other procedures should also be taken into consideration when a treatment decision is made for these high-risk patients with the calcified coronary lesion. As we know, severe coronary artery calcification presents very, very complex and a very severe challenge for PCI, and for these reasons, PCI is associated with low rate of procedure success and high risk of angiographic complications and high risk of MACE, that is the major adverse cardiovascular event.
Yeah, thank you, Dr. Gong. And actually, I think it's really great. And maybe I want to add some comments. And the first, like Dr. Gong said, we have three truths about the PCI and TAVI. So the first is about the pre-procedure step, like the PCI is performed before TAVI, and maybe it has some increased risk of the PCI because of the hemodynamic instability caused by the aorta stenosis during PCI. And the second is like the today case, it's a one-stop, the PCI and TAVI, and it's maybe increased. It also may have reduced the risk of the patient's trauma during both procedures and increased use of the intraoperator contrast and prolong the procedure time may increase the risk about the kidney diseases, the risk, and heart failure. But actually, in China, we have so many BAV patients, and because of this situation, the higher percent of the patients with combined cardiovascular diseases and use of the self-expanding valve, like the Torres Elite, with longer valve stand than the ball expanding valve. So our expert agrees that the inter-operator one-stop and the pre-operator operation stage are more approximately for the treatment and strategy for our population. So that's my comments. Thank you, Dr. Dong, and thank you, Dr. Tu.
Okay. This question, additional topics and comments. I think PCI before TAVR might be associated with lower contrast volume and less radiation exposure during the same procedure when compared to concomitant PCI and TAVR. PCI before TAVR might reduce the incidence of hemodynamic instability during TAVR and offering protection during rapid pacing and period of hypertension. As for this patient, the left ventricular ejection fraction was only 13%, and the coronary angiography demonstrated significant stenosis of RCA and circumflex. Inferiorly, femoral access for TAVR in patients recently treated with DES or DEB that DAPT might lead to high risk of blinding and vascular complication during TAVR. This is my option, Professor Liu and Professor Tu.
Thank you very much for Professor Gong's comments. Okay. 这主路呢，这辅助呢不真的占了，是吧？把这个东西介绍。Okay, Professor Sun has established a central venous line, insert a temporary pacemaker catheter via the right jugular vein, and insert a 6 French introducer sheath into the secondary access artery from the right radial artery.
Finish about the angiography, about the mean size. And now Dr. Tu will introduce about the TAVR procedure, like the valvular size. So please, Dr. Tu.
Okay, we will insert 20 French introducer sheaths into the right femoral artery main access, and administer the anticoagulant heparin and check the activate clotting time ACT after the initial heparin push, and recheck every 30 minutes thereafter. Maintain ACT more than 250 seconds. And advance the pigtail catheter to the ascending artery and position the distal tip in the long corollary cuffs of the native aortic valve. Identify the ideal annular viewing plane using the contrast injection at various angiographic angles. And then insert an angiographic catheter over a standard G-tip, get well into the primary access sheath, and advance to the ascending artery.
So now Dr. Sun is do the operation stably, and now maybe we can do some discussion. And so for the discussion part, and so Dr. Tu, would you like to talk about the BAV in China and overseas, the differences between them? So yeah, actually I want to do some comments about the BAV, the situation, differences between the China and the overseas. And actually in China, we can see that so many patients have the BAV, the aorta type, and it's almost 40% for BAV and 60% for TAV. And for the overseas, the analysis the paper shows that the maybe the BAV population is only 10% and TAV is almost 90%. And for the BAV, the type 0 is almost about the 10%, and the type 1 is almost 90%. And the prevalence about the BAV patients in China is significantly higher than in the West and even in other Asian countries like the Thai and other regions. Of these patients, study has shown that maybe almost 30% to 50% was treated with TAVR for the BAV. And the BAV is significantly more classification than the TAV. It means that maybe the classification score in BAV case is more than significantly more than a TAV case. And the angle between the horizon plan and the annular plan was greater that of the TAV. It means that maybe the BAV patients, so many percent of the patient have the transverse heart. It may be at the risk of the operation. So I think maybe it means the heart case. And diameter of the AAO was significantly larger in the BAV case and consistent with the AAO dilation due to the hemodynamic of the BAV. And for Professor Tu and Professor Gong, would you want to add some comments about the differences between the BAV patients like the China and overseas countries differences?
How we exchange the GT where those Swift where. 是要22这个是。Bicuspid aortic valve deformity is a common congenital cardiac anomaly, which is reported to exist in 30% to 50% of adult patients undergoing aortic valve replacement surgery for severe aortic stenosis. Historically, BAV has been considered a relative contradiction for TAVR and has been excluded from the major TAVR trials, primarily owing to the technical difficulties and procedure risks associated with its unfavorable valvular anatomies. A BAV is considered to contradicate TAVR because of the poor stability of the prosthetic valve and paravalvular regurgitations due to the distortion of the lateral valve leaflets.
Okay, thank you very much about Professor Tu introduction, and I really agree with the BAV situation about the differences between the China and the overseas. And now, Dr. Sun, are you doing the transvalvular step, right, Dr. Sun? Yeah, maybe the doctor is doing the transvalvular step. And now, maybe Dr. Tu, could you introduce about the transvalvular step, like how to do that, and be some tips you can give us? Yeah.
What? 你把这些关了。心脏不联动呢？
Sure. Actually, when we do this step about the transvalvular step, we usually use the AL catheter, and we use the straight line guidewire to do the transvalvular step. And for this step, we usually like some tips for this step. We usually do the supravalvular plan to do that, and we will wait for the heartbeat and aorta valve open and close, and wait for the great time, and we will do the transvalvular step. We will maybe just push the straight line guidewire first, and we will followed by the LV catheter, and we will do this step successfully. And this is for this step introduction and comments. Yeah.
Hello everyone. We will try to transvalve now.
Okay, and Dr. Sun just said he will do the transvalvular step, and we can see the motion about Dr. Sun how to do that.外头有的手上实在没有办法。刚才这会儿是没好使，我倒影没踩出来。猜到了，猜到我框框已经接上，没事。现在能，现在可以，现在还不能造影。Now we meet problem about the we can't land the DSC and the angiography, so we will call the engineer to deal with this problem. 从别的模式换成冠脉模式，现在现在。
Okay, Professor advance the straight tip guidewire across the lateral aortic valve into the left ventricle. After crossing the lateral ventricle with the guidewire, advance the AL1 angiographic catheter into the left ventricle.
Okay, I success to the transvalve.
Yeah, Dr. Sun just successfully transvalvular use the guidewire and use the AL catheter. And now we will exchange the guidewire, and we will change the straight guidewire to the G head guidewire, and we will also exchange the catheter, the AL catheter, to the pigtail catheter.它转播切到那个屏幕吗？那个屏幕。今天主要是噪音没有办法找解决方案。
And now we remove the guide wire and collect the catheter to the transducer. Using both catheters, record the optical pressure gradient.
And it's about the pigtail shows data is 95 and 65, and okay, we can see. Okay, the LV pressure shows it's about 120, and the next is about almost 40. Okay, and the Dr. Sun has finished about the step, like the exchange the catheter from the AL1 to pigtail, and use the pigtail to do the blood pressure test, and the blood pressure test shows it's great, it's stable. Okay, we can wait.
Lead shoot. Open. Now we can scream after the press of the LV button and the pressure of the AO.
Okay, actually, we finished about the airport hub and the transcellular ventricle pressure test and use the pigtail, and we found that the transcellular gradient value is not really high. It's almost 20, but we have to do the pre-operation echo, and the echo shows that it's a normal condition, and we have found this condition pre-operation, so we think now it's normal. it's normal condition. We don't need to worry about that. The transvalvular gradient is almost 20. We think we don't need to worry that. Okay. Great. Fortunately, now our angiography have aligned to the DSC with angiography. We have called the engineer and we repair that. And now we use the pigtail to do the angiography, and we can see the situation about the aorta root.
Lundquist required, maybe. Lundquist may be required.
And from the angiography, we can see the classification situation and the restriction.
Maybe.
Condition is almost same like the CT analysis. It's the restriction range is from the 4 to 10 millimeter. And now we will exchange the guidewire. We want to exchange the guidewire to Lundquist, the super stiff guidewire.
Open Lundquist. Another.
And now we remove the pigtail gesture while maintaining the high support guidewire position in the left ventricle.
It's
Professor Sun, for this patient, what balloon dilation strategy would you adopt for this patient? The septal configuration for BAV leaflets differs significantly from that of the transcarpate aortic valve. The leaflet defines three-dimensional supra-annular landing zone in the BAV tends to be progressive, more constrained toward the orifice and can hardly be reshaped with cylindrical balloon because of the restriction at the orifice level, particularly in the presence of a significant calcification and inadequate preparation will pose significant challenges for stable valve positioning and might result in migration or even embolization into the left ventricle. And what balloon size would you like to choose for this patient?
Yeah, thank you, Professor Tu. And for these patients, we do so much CT analysis before the operation. And we do this strategy based on these patients have a BAV valve with annulus of 27.9 and from 2 to 10 millimeters supravalvular anchorage interval in the range of the 24.7 to 27.3 millimeter. And based on the annulus and supravalvular restriction, we measure the AV29. Yeah, the AV29 valve oversize as 9.3 to 13.2%, and the AV26 at 0.9 to 5.2%. So we choose the Torres, or we choose the Torres Elite valve, the AV29.
Now, now we check the valve.
Yeah, now the Torres Elite, the valve delivery system has pushed into the access.
Okay. Low.
Okay, we have checked the aorta delivery system under the DSA. So we will follow about the last question is about choosing the balloon size, right? Okay, and in inner operation, we will also verify the degree of the supravalvular restriction and the valve strategy selected by balloon sizing for the validation of the degree of the supravalvular restriction and the choose of the valvular strategy. As for Dr. Sun.
Hello. Now, we will balloon dilation. Now the CPB is start. Okay, CPB start.
Okay, great.
Good luck.
And now Dr. Sun will do the balloon pre-dilation. And Dr. Tu, would you like to introduce about this procedure?
Okay. For this patient, and which special valve system do you want to select, Professor Liu, and why?
Yeah, like I said, we choose the Torres Elite AV29 valve for this case and use the balloon size like the 22, because we found that they have the moderate to severe classification situation from the 4 to 10 millimeter supravenular analysis, and we think if we want to reduce the risk of the leaflet tear, we need to maybe adopt a small balloon pre-extension strategy. So we choose the 22 millimeter tertiary artery balloon. So that's the reason.
Yes. Pacemaker. Okay. You start. Okay. We'll start.
Okay, now we will.
Oh, okay. Stop. Okay. Sorry.
Okay.
Well, let's start. Okay. Okay.
避免下来。
Start. Oh,
okay, now we start the balloon dilation.
Okay, hello.
And we think it's not stable, and we will wait for that. We will wait the ventricle to be stable, and now we try again. So we want to find an ideal position for the balloon dilation. Okay, from the angiography, we think this balloon dilation, the performance is great. Do you think that, do you like the same comments, Dr. Sun? Do you think the balloon dilation is great?
Pacing stop. Okay.
So, Dr. Sun, do you think the balloon dilation performance is great?
Yes.
Right, fantastic.
Performance.
Yeah, the performance is great.
So we choose the valve size 29.
Okay, and now we will do the Torres Elite the delivery system for the AV29, like we did the strategy before the operation.
Last picture.
Last picture, okay.
Okay, last.
上一张图怎么上一张图调一下，这个是怎么调的？我看上一张图，我知道。
constrict fluid. Date the constrict fluid. Yeah. Mu. Last picture.
This one, right?
And next.
The next, right? Okay, the next.
Okay, yeah,
okay.
Okay, from the angiography results, we find that there is no coronary artery occlusion and no obvious leakage. Additionally, you can see the obvious balloon with the sign. So we choose a 23 millimeter balloon. Pre-dilation strategy is reasonable, I think.
Yeah, I agree with that.